Hello and welcome to On the Same Page, a new series of intergenerational conversations by changing the narrative in Colorado. My name is Dominic Dezzutti, and I'm your host, and thank you so much for joining us. I am joined today by a very diverse group of people to discuss why health equity is so important in our society right now. Allow me to introduce our esteemed panel. Tony Baruti, board member from the Center of African-American Health. Webb Brown, director of the Colorado Office of Health Equity. Christine Burrows, Director of Older Adult Services at Easter Seals of Colorado. Joanna Cintron, Executive Director at Revision. Adela Flores Brennan, Executive Director at Colorado Consumer Health Initiative. Rudy Gonzalez, Executive Director for Servicios de la Raza. Gosha Kung, Architect and Board Member at the Denver Planning Board. And Natalie Vogan, Associate Director of Programs at Colorado Rural Health Center. Everybody, thank you so much for joining us. We're going to I think, really provide a great service for our viewers today to talk about a very important topic. Let's start with the definition for our viewers at home. What does health equity mean? Webb, I want to start with you. Since you're the director at Colorado's Office of Health Equity, how does Colorado define it? And in your view, how equitable are health systems in Colorado right now?
Thank you very much for having me. There are lots of different definitions of equity. The official definition used by the Office of Health Equity is equity is when everyone, regardless of who they are or where they come from, has the opportunity to thrive. This requires eliminating barriers like poverty and repairing injustices in systems, such as education, health, criminal justice, and transportation. But a simpler definition that I like is that equity is when your identity has no impact on your outcomes. In other words, it doesn't matter who you are, your race, your religion, your sexual orientation, ability level, etc. All of those social identities have no impact on your ability to achieve in life. Now, the reason my office exists is because we've got so far to go in order to get there. And the data tells us that your social identity, whatever it happens to be, has everything to do with your life outcomes. As it relates to health systems in Colorado and actually the country more broadly, the country is experiencing the same equity challenges as other systems, such as housing, education, or criminal justice. So health inequities are multi-sectored, multi-layered issues with significant impacts at the social, economic, and health levels.
Well, Adela, I want to go to you next. Equity is one of the core values for the Colorado Consumer Health Initiative. How do you define it? And the same question as we asked Webb, in your view, how equitable are health systems in Colorado right now?
To me, health equity is about addressing the specific needs of communities that continue to face the systems level and structural barriers that Webb just talked about. For us, it means that we need to target solutions that address systemic racism and social, economic, and resource barriers that people are facing. And it means that we need to work with the communities who are facing those barriers to help build their power and identify the needs and solutions that work for them. I think that for us, since we're a healthcare advocacy organization, when we look at inequities in the system, we do think we've made significant progress since the 2014 implementation of the Affordable Care Act, because it provided important gateways to accessing healthcare through granting people more coverage. Particularly the Medicaid expansion was really important because it provides really targeted, low-cost health coverage that is really comprehensive. But that doesn't mean that everybody has experienced that increased access, that everybody has been able to translate that access into care or better health outcomes, that they have transportation to get to the doctor or money to be able to fund the prescriptions that they need to control their chronic illness. And it also doesn't mean that everybody is included. We have significant gaps in the system right now that actually exclude people based on their immigration status. And so we can't achieve full equity in healthcare until we can achieve greater universality.
I think you raised a great point. Joanna, I want to go to you next, because when we think about access, I think that it's an important topic, but it's also broad. When we think about just healthy food, nutritious food. I think it's hard for some folks to even think that access is a problem in the United States of America, that everybody has 4 grocery stores within a half a mile from their house. But that isn't always the case. Can you share with us a bit more about how access to healthy, nutritious food is an element of health equity?
So at Revision, we really believe in equity as an action and a practice. And so for us, we are really dismantling the structural inequities and structural racism through food. We're using food as a way to address the inequities in the food system. Systemic racism shows up in community in a lot of different ways. For us, it just happens to be food. Many places are familiar with the term food desert. And for us, we believe that one of the ways for every Coloradan to achieve their highest possible level of health, regardless of their skin color or where they were born or what zip code they live in, is through access to healthy food. And so that's sort of our practice in helping achieve a more equitable playing field in public health.
Well, it certainly makes a lot of sense to me. And I love your point about people not understanding food deserts and even growing their own food. As a gardener myself, I know that's an important issue and a way a lot of people can think about getting access to more healthy and nutritious food. Gosha, I want to go to you next. When people think about health, they don't necessarily think about housing and the built environment, but those are very important issues here. Tell us a bit about why those are important components of health equity.
Yes, thank you for that question. I think, housing is something that we refer to as social determinant of health. And there's some direct impacts of access to housing or lack of housing, access to housing on health. So some of these are very obvious and intuitive. So obviously homelessness has very negative impacts on one's health, but also there's groups of demographics that are housing insecure, so susceptible to eviction, frequent moves, moving, seeking for rent discount. So that obviously causes a lot of trauma. Stress has impact on mental health as well as physical health. It affects performance of children at school. So there's this very direct and very intuitive elements of housing, but there's also a bigger context to that conversation, and it's about community design and neighborhood design. So it's not just having a home, but where that home is located has impacts on health. So living in a walkable community obviously provides better results on health. Having access to transit and jobs and opportunities, living near a school or a park or a trail has positive impacts on health, whereas living near a highway has results in asthma and other challenges. And where people live and how those communities are designed and how they're reflected in our land use policies also has effect on different demographics, their background, financial means, as well as racial background. There's a lot of challenges in terms of equitable distribution, housing, and providing access to healthy communities for different demographics.
Well, it certainly feels that is a big part of the conversation. I'm so glad that you're here. We're able to kind of talk about that part of it. Now, health equity is an important issue, not only in Colorado, but throughout the country, even when we don't have a pandemic. But frankly, the pandemic has, in a lot of ways, exposed a lot of big problems. And it's been said that the pandemic has exposed systemic inequities and fault lines in our society. When we think about that in terms of health equity, I want to ask more of our panel here what they've seen. Tony, I want to start with you. Data from around the country is clearly showing disproportionate impact of COVID-19 on African Americans. Can you tell us a bit more about how systemic inequities have led to that and what you're hearing at the center?
Well, what we're seeing, especially within the African American community, what COVID-19 did was it exposed to the world what the African American community has known for years. we can go back to 1899 when W.E.B. Du Bois wrote the book, The Philadelphia Negro, that spoke about the outcomes of African American health compared to white health outcomes, and that it was due to living conditions other than genetics. And so that's really the reason why the Center for African American Health exists, is so that we can offer those culturally sound resources for African Americans, so that we can kind of navigate through the systemic inequalities. It's really pretty much within African American life. It impacts every aspect of life, from education, from housing, to food deserts, to healthcare. We are living in a system under a government that was not designed with us in mind, and really was designed systematically to keep us out. So being able to navigate through that system, we would have to go back to the Constitution to dismantle systemic inequalities for African Americans.
It really seems that this whole, not just COVID, but we're in a time of defining and looking back to really see how systemic, how ingrained a lot of these issues have been. I think that's a great point. Rudy, I want to go to you next. Servicios provides lots of services to people of all ages in the Latinx community and beyond. What are you seeing now?
You know, first I'd like to start off with saying Black Lives Matter and Happy Pride Month. Another demographic that is discriminated against and suffers huge inequities. You know, Servicios de la Raza, we have transitioned to remote virtual work as of March 15th. We are phasing in our building and our office reopening this Monday. We have since been serving remotely and virtually. Approximately 95% of our services remotely and virtually, and still responding to food and toiletries for senior communities, immigrant communities, COVID positive immigrant communities across Denver Metro, at over 500 being delivered and engaged per week since March 15. We provide a huge array of services. We're probably the largest one-stop human service provider in the state that is culturally responsive and linguistically specific and expert in the Latino community, although we serve everyone who comes through our doors. But I just want to say around systemic issues is that we cannot return to normal, pre-pandemic normal, because that wasn't normal for us in our communities. As Latino communities, I say Latino, but I'm Chicano, I identify like that because I'm indigenous to this hemisphere. We didn't cross any border, the border crossed us. We are indigenous to this hemisphere, and as such, we suffer a lot of the common issues of other communities of color across this country. And those issues of economic inequities, all those social determinants of health, you know, and so we don't want to return to the normal of pre-pandemic. We need to use this. This pandemic has really exposed stark inequities with our communities, especially, you know, with COVID. 23.8% of the deaths are Latino deaths in Colorado. We have 28,000 COVID cases at this point. 37.9% are Latino at this point. And so obviously we're about 20% of the state, give or take. And, you know, there are those inequities, right? Those systemic inequities. Servicios works not only to provide services and try to alleviate those inequities and help families and individuals at a crisis, but also keep them from falling into crisis, help our vulnerable communities. And so we are working across the state in this work. We're doing a lot of telehealth. We really upgraded our IT and our technology as a result. And we've also learned how to serve robustly through the use of technology. And so it's been a great lesson for us. But again, you know, we don't want to return to what everyone thinks of as normal, that was pre-pandemic, because it wasn't a good normal for our communities, and just across
Rudy,
the spectrum.
Rudy, let me ask a follow-up to that question, because I think it's easy to forget that not only do we have multiple generational Latinx communities within Colorado, but we also have important immigrant populations. Have you seen issues in this issue about health equity that are directly impacting our immigrant communities as well?
Certainly. You know, our immigrant communities, we have, our messaging has not been, the messaging that comes from government and private and public sector has been confusing for immigrant communities. It hasn't been consistent. We're hopeful to get that corrected. Been serving on the health equity response team for the state with Webb and others, and across the state, and trying to create more equity in that, in the messaging, and more cultural responsivity in that messaging. That's going, you know, we're a very nuanced community. We have, you know, approximately 1.3 million Latinos in the state. 800,000, like me, are native English speakers, multi-generational, and 500,000 are native Spanish speakers, monolingual and bilingual, and low proficient English users. Also, we have many people who have a low literacy rate, and so we have to consider that in our messaging. And you know, it's around access. It's always around health access to health care. You know, we have a lot of underlying conditions in our communities, including diabetes, including other health conditions that, you know, that are reflective of our socioeconomic status, those stark inequities there. And so, you know, again, we have a really opportunity during this pandemic to change and create some real systemic change, so we don't come back to normal. We create a new normal. We create a new paradigm that will start addressing and creating change, real change for our communities.
That's a great point, Rudy. Thank you for expanding on that. Natalie, I want to go to you because I think it's easy. I know it's easy for me to forget how big Colorado is. Colorado is an enormous state. And while we hear a lot about issues, and there's a lot of people that live in the Denver metro area, frankly, our rural population is enormous and really spaced out. We have, 47 out of the 64 counties in Colorado are rural and frontier. You think about the different issues we're facing, even with food deserts and equity issues with healthcare right here in the middle of the metro area. But gosh, you go to Lamar, La Junta, Yuma, Meeker, you can really rattle a lot of them off. I got to believe there's some specific issues hitting our rural neighbors. How has the pandemic been impacting rural Colorado?
Yeah, thank you, Dominic, so much. You know, as you mentioned, we do live in a very, very large state. I will say, Saguache County alone over on the western slope is as big as the state of Rhode Island. So that puts it into perspective for you just how big the state of Colorado is, how diverse the state is from the eastern plains all the way to the western slope, and just the different issues that rural Coloradans face. And so, you know, I would say what we know is that rural Colorado hasn't been hit by the pandemic as hard as the urban Front Range. However, the shockwaves from the pandemic have been felt deeply in rural communities. So, you know, the pandemic has greatly impacted rural Colorado in a number of ways. And one thing I wanted to just kind of bring up and focus on initially is this idea of isolation. And, you know, rural Colorado many of the residents in rural Colorado were already very, very isolated. As you mentioned, we've got 47% of the state that's considered rural. We have frontier counties. We've got just very, very isolated areas where people do not have access to the normal day-to-day things that we think about, going to a grocery store quickly, accessing their healthcare provider in a quick manner. And so as imposed stay-at-home orders, were put upon the state, many rural residents who are already isolated were even more isolated. And many of those were older adults living alone. They were confined to their homes, and individuals and families that were already isolated in very remote areas of the state were suddenly cut off from everything. So, and in some cases, we have to consider this as their lifelines too. And, we've talked a lot about just, different health disparities and things like that in Colorado. And I would say rural Colorado residents, like much of rural America, experience poorer health outcomes than the rest of the state. So, this can be linked to a growing older population, higher rates of poverty, lack of health insurance, and poorer access to health care. So we simply don't have, the primary care services, especially care services that we need to serve our rural Colorado population. And I would say under the dark cloud of the pandemic, unfortunately, people who live in rural, remote areas who need to be seen by their primary care providers frequently to deal with chronic conditions, they're suddenly cut off from doing so. We moved very quickly to a stay-at-home order that prevented those patients from figuring out solutions on how to connect with their primary care providers and the providers in their rural healthcare settings. And so that's something that our members, our rural hospital members, our rural clinic members have been very concerned about during this entire pandemic. And it's extremely concerning for patients who are suffering from chronic conditions, who need vital routine care, and that's not something that they can put off. So really making that transition into continuity of care and how can we come up with solutions to be able to bring care to patients in their homes. And we talked a lot about the patients. I do want to bring up the patients, these people in rural Colorado have been impacted by COVID-19, but I also think it's important on the providers of healthcare in rural Colorado. Hospitals and clinics across rural Colorado are struggling financially very much as patient visits plummeted. So just to give you an idea, according to a survey to our rural primary care clinic members, they've seen an average of a 70% decrease in patient visits during the pandemic. So that's very alarming. When we already think about the fact that, their revenue, depends on how many patient visits they're getting into their clinics, and with imposed stay-at-home orders and just kind of the, I would say the communication around the pandemic, it has caused a lot of confusion for people in rural areas. And so they have essentially stopped going into their primary care provider. They've stopped going into the hospital. And this is revenue that they depend on to pay their employees, purchase supplies, and ultimately keep their doors open. So that's really something that we've been focused on, obviously very concerned about here at Colorado Rural Health Center, and trying to understand those implications, and then also the long-term implications of that. Because when we talk about dips in revenue, when we talk about plummeting patient visits, that's not something that turns around quickly. And we often don't think about on the urban, the Front Range area when we go to a place like Salida, Colorado, or when we go to a place on the Eastern Plains. We don't think about, oh, I wonder what their hospital is like here, right? Unless something happens to us. It's a shame to see how many places in the state they don't have access to just basic health care. So that's something that we've definitely been taking into consideration. That's part of our mission as an organization, but something that's definitely been highlighted with this pandemic.
Well, Christine, it really does feel that throughout this conversation so far, which has been great with all of our different panelists, that we've been talking about a lot of different communities. Communities of people of color, our communities that are out in the rural Front Range. Another community I think that is part of the changes and really suffering from a lot of different problems during this pandemic is our older adults. And I think, frankly, it feels that many people have said that, ageism has been exposed through the pandemic. There's been terms like boomer remover being used, and people suggesting that the older people be sacrificed for the economy. And can you tell us a bit more about that and the harmful health effects that experiencing ageism has on older people?
Certainly. So, terms like boomer remover or phrases like, only older people are dying from COVID, so it's not that big of a deal, have been circulating throughout the course of the pandemic. And this kind of rhetoric is so dangerous for older adults, because when we create this collective devaluing of older adults through this narrative, it goes from a colloquial conversation topic to policy change. And that's where we get really concerned with the systemic ageism. So I can, from a policy standpoint, a couple months ago, the state released the crisis standards of care. And this is essentially a decision tree that says, if so many people come into the hospital needing ventilators because of COVID, and there aren't enough ventilators to provide, this is the decision tree that we're going to use to determine who's going to get a ventilator. Well, unfortunately, one of the criteria within the crisis standards of care is life years saved. So if two people, maybe one person age 60 and one person age 30 go into the hospital and they look very similar health-wise, the person who's 30 is going to receive the ventilator because they have more life years saved, perceivably, like more life years saved. And so at first, right away, older adults are disadvantaged from receiving life-saving services because we've sort of created this devaluing idea about older adults. And I know there's several pieces to this puzzle, but another aspect that we've seen is this collective stay at home if you're over 60, which I think comes from good intentions, but it has very dangerous impacts on what occurs if you stay home if you're over 60. So I think people with comorbidities and chronic health conditions can also be roped into this category as well. When we ask people to stay home in order to keep them safe, we also are risking other aspects of health equity that I think are important. So as a public health professional myself, I'm looking at people with comorbidities and chronic health conditions are at greater risk of needing hospital care if they are infected with COVID. So how do we keep people safe from being infected with COVID? And that has been identified as staying at home. But there are also other really important aspects of staying at home that we need to take into consideration. Like Natalie mentioned, social isolation. That's a huge one. If people are being asked to stay at home, as Colorado is starting to reopen, that opens up some doors for employers to say, oh, you're at high risk and you're older. Can we terminate you because you can't come to work? And of course there are policies surrounding that, but we create this further devaluing of older adults when we do, and people with chronic health conditions that when we create blanket statements like this. And that's one of the things that I get concerned about with health equity. And I wish it was more cut and dry, but there's so many pieces to take into consideration. And unfortunately with this pandemic, we've needed to make decisions really, really quickly. And I think we need to do a little bit of readjustment and reassessment on how we can identify health equity and health disparity issues when people are staying at home, or perhaps if they can't stay at home, if they don't have a safe home to stay in, or losing their job or having mental health issues. There's so many pieces of this puzzle, and it really is, I could talk about this for hours, it really is such a challenging piece of this, of health equity, to really make sure that even if you are older or have chronic health conditions, like Webb mentioned, talking about how the state defines health equity, who you are shouldn't affect what you can achieve. And so if you're older, if you have chronic conditions, that shouldn't affect what you can achieve in this pandemic.
Christine, I think you make very good points. I think it's easy to think that something doesn't exist that hits home. And I think your example there about, if resources got tight, would a hospital say, a 30-year-old got a ventilator before a 60-year-old. Well, you're thinking if it's just an option of A and B, you're looking from the outside of it. Well, oh gosh, it's this kind of technical decision. Until that 65, 70-year-old is your mom or your dad or your aunt or your uncle, then you're thinking, well, wait a second, why am I making a choice? So our hospitals shouldn't have to be making Sophie's choices for our society. And I think you bring up some great points. One of the things I love about On the Same Page in this series that I am so grateful to be a part of is that it not only talks about here are some issues we need to be aware of in our society and in the Colorado community, but what can we do about it? What are some the strategies and innovations out there that are making some progress? So it's not just about, hey, here's some important things we need to address, but here's some ways, something we can do about it. It's a positive message, and I've always enjoyed being a part of that. So now we're at the part of a show, but we're going to get into some of the promising strategies and innovations that are addressing these inequities. Webb and Adela, I want to come to you first. Webb, we're going to come to you. What are some of the policy efforts that are important on a statewide or even a national level? What systems need to change? Webb, let's go into you.
Thank you. That's a great question. And I'm going to focus my response at the national level, simply because I think that's where so many of the inequities that we face currently on a historical basis really originate. So the short answer to your second question in terms of what systems need to change is all of them, right? None of our systems, whether we're talking housing, transportation, education, criminal justice, and more, were built with us in mind. And when I say us, I mean people of color. They were built to advantage some at the disadvantage of others. So through historical policy decisions such as redlining, our systems, again, were designed to advantage some at the disadvantage of others. So for those not familiar with redlining, it's a federally created policy that existed for over 30 years until the mid-1960s that discouraged banks from lending money in communities of color so that residents in those communities could purchase homes. It also discouraged building of new homes in communities of color. So I want you to think about what that means for a second in terms of the generational impact that a policy like that would have. So if banks were not able to lend money or discouraged from lending money to people who live in communities of color, to residents of color, what does that mean from a generational standpoint, right? So if you think about what home ownership means to you in terms of your kids, your grandkids, and future generations, it means that you have the ability to put the next generation through college. It means that you have the ability to retire with dignity. It means that you have the ability to pass that generationally generated wealth on to the next generation who can then grow it and pass it on, grow it and pass it on, etc. But then think about just the opposite. If you did not have the ability to generate that wealth from home ownership, what does that mean, right? So if you are a resident living in a poor community of color, did not have the ability to purchase a home, your kids are going to failing schools in that disinvested community, etc. What does that mean for their future? What does that mean in terms of your lack of ability to foster generational wealth, your lack of ability to put the next generation through college and to retire with dignity, etc.? So at the root of all of the inequities that we face as a society is really economic inequality that, again, has been historically sanctioned and historically created. So the economic inequality that we face today as a country has its roots in those policy decisions that I mentioned earlier. So that's both a good news and a bad news situation, because if the bad news is the inequality, the inequities that we face today as a society are created by policy, the good news is that policy is also the answer to undo all of the harm that was created by those previously created policies. So we really need to focus on addressing those economic securities, as I mentioned. So federal policies like raising the minimum wage, creating conditions where people have the ability to go to work and earn a living wage to be able to support themselves and their families and their communities in which they live.
Well, let me jump in real quick. I apologize to interrupt you, but I want to be sure we get to the whole idea of affordable housing, because I think we hear a lot about that, but I don't think we get into a lot of details. Give us such a short, what you think needs to be done in this area.
We've got to create policies designed to eliminate residential segregation. As long as we continue to have racially segregated communities that are disinvested, have poor schools, and where people don't want to live, then we're going to continue to have the types of economic inequality and insecurity that we currently are dealing with. So we've got to create, through policy solutions, conditions where different groups of people, different socioeconomic rates, different groups of people per race are able to come together to live in community, to have access to the necessary resources within their communities that create conditions where everyone can thrive. And finally, investing in education is also going to be a key. Beginning in early childhood, all of these have been associated with increased economic mobility, and I think that's really where the federal policies need to focus.
Adela, I want to throw it to you now, because there's a lot of things that we need to address, but a lot of different ways we can do it. So as you're looking at all these different policies, not only what needs to change, but what are some of those changes that you think are on the horizon that can make a difference? Adela, let's go to you.
Thanks. And I think, of course, I totally agree with Webb that we have to be thinking about health equity in terms of all of the factors that influence people's well-being and health. So that includes housing and transportation and access to healthy foods. In addition to that, we also have to be thinking about the whole patient. So we really need to be focusing on policies that continue to address access to mental health and access to oral health care, in addition to addressing the physical health. We have to take care of the full person, the full body. And then in terms of systems, there are so many things that right now are being highlighted by the pandemic. And I think one of those big things is access to healthcare itself, access to the coverage as the gateway to healthcare. So we've seen a huge increase in numbers of enrollments through the state marketplace for insurance. We're seeing increases in enrollments through Medicaid. So in terms of public policy, we really need to be able to strengthen those systems and maintain those systems and create opportunities to put more money into the Medicaid program, especially because that's going to be the program that is most responsive in terms of being able to support people who are economically and in terms of their health care being affected by the pandemic. And so really shoring up the Medicaid program, both at the national level and at the state level, that's incredibly important right now as the state is facing $3 billion in budget cuts. So we need to be looking to our federal partners to be able to get some relief into the state so that those cuts don't affect benefits and don't affect access for people who need it. And then we also need to make sure that people who are accessing healthcare aren't facing significant medical debt or collections or those types of problems associated with cost and affordability that only serve to further jeopardize their economic security. And if you're jeopardizing economic security and creating that toxic stress, you're also jeopardizing health and well-being and mental health. So there's also a few other policies that we're working on right now at the state level to help increase access for people who are being left out of the system right now. So there's a lot of talk right now about developing a public option, and then going through the legislature at this moment is a health insurance affordability measure that will create additional subsidies for people who are low income and will create opportunities and subsidies for people who have been left out of the healthcare system so far. So those are a lot of things that I rattled off right now. There's so many policies that we're working on and that need to be furthered or advanced in order to change systems, but that's just a little tidbit.
Well, certainly there's a lot of things to do. I'm glad there's a big shopping list. That Adela, that's a good thing in my eyes, because that means while it's a lot of things to do, that there are a lot of things possible. And that's certainly what this program has been about. Natalie, I want to go to you next, because thinking about policies and the rural area, and with your role representing a lot of those communities, I think are easily forgotten in the Denver metro area. What might you add to this conversation that might help even the playing field in rural Colorado?
Yeah, so, just to kind of piggyback on everything everyone else is saying, I think that, in our eyes, policy is a really big focus for us right now. And, I think that one thing people don't realize about rural Colorado, and I think just rural America in general, is we hadn't fully recovered from the recession. Unlike a lot of our urban counterparts, there were still certainly areas of rural Colorado that were very, very hard hit from the recession and still trying to recover. And so now what we're facing is another economic crisis and just some uncertainty as far as our state budget goes, and with what the outlook will be over the next year, 2 years, 3 years. And so, one thing that we really wanted to dive right into was this policy piece. And so we have a really robust policy department through Colorado Rural Health Center. And so our policy manager is working on a rural stimulus bill right now. And that brings together a diverse group of rural stakeholders who are advocating as a coalition for an aid package in rural Colorado. So this is really, really important. The group is proposing a rural stimulus package that sends critical funding to rural schools, hospitals, clinics, businesses, and agriculture. So a lot of those key players in our rural communities as far as economic drivers go. And each of these critical sectors, like I mentioned, were already struggling to remain competitive prior to the recession and simply cannot withstand the realities posed by the current fiscal crisis without additional support. So that's definitely something that we're really focused on. We're working with the group, Colorado Rural Health Center included. We're working with state and federal partners to leverage any aid that comes down to ensure that rural is not once again left behind in a recovery. And one thing that we really try to do here in Colorado Rural Health Center with our policy and advocacy program is really try and kind of translate and align things with what's happening in rural communities. I think a lot of times what happens with policy that comes down from both the state and federal level is it's kind of a Band-Aid fix for things. However, these programs and these policies that are implemented at the state level and in urban communities, it may work here, but it doesn't necessarily work in each of these unique and diverse rural areas. So we're hopeful that something like this rural stimulus package, where we can really focus on each of these sectors and really dive in more at the community level to get some feedback and really hear from community partners and community voices about what that change needs to look like and what that support needs to look like, then we can advocate at the state and federal level on behalf of those individuals. So that's one big thing. And another thing that I really am a big promoter of right now is I cannot stress enough how important the census is. So we at Colorado Rural Health Center, we actually got a grant this year to work on rural outreach and community support in regards to the census. So as we know, residents in rural communities are generally pretty resistant to sharing their information with the government. So, really with that grant, we just took a lot of time to pull together tools, simple educational references, mailers, flyers. We actually had a census question hotline for people to call into that just had questions about the census. What is this? Why am I filling this out? And really, it was an opportunity for us to provide some education as well. We know that the census affects the amount of funding all the communities across the state receive, how their community plans for the future, and the representation in the government. And it's just really important that we, again, provide education, provide resources to make sure that the rural voice is represented with the census. And then one more thing, that I want to mention. So the census is a catalyst, I would say, for addressing the 5 social determinants of health, which have come up quite frequently in this conversation. So the economic stability, social and community context, neighborhood and environment, healthcare and education. So we really recognize the connections within key community partners, and a strong infrastructure for addressing social risk factors have helped close some of those gaps in rural communities. And many of those efforts have been started at the community level. And so I think just this simple education that we can do around the census also helps us really dive into more grassroots efforts that they can be doing at a local level, how they connect with their local representatives, what policies are happening, that are going to impact rural communities, and really just, again, getting more rural representation, more representation from the rural voice. And I think that's something that we really try to focus on here. And, even though we're the Colorado Rural Health Center, we support rural hospitals and rural clinics. We know that they're usually a foundation builder. They're usually a really stable point in these rural communities. So there's a lot that we can do as far as communicating through the hospital and through the clinic to make sure that those community members are advocating for themselves.
Well, right before we got started, I talked to all of our panelists, warning them it is amazing how fast an hour goes by in this kind of discussion. When you have great people and great input, that's what makes it go by so quickly. So we're headed into our final stretch here, so ask for some of our shorter answers from our folks. Gosha, I want to go to you next because you have done a lot of work and you're a big advocate for changes in housing policy. And because that is something that I think has a longer time estimate. People think about that not happening today, but it's got to happen in the future to really make an impact. Tell us a little bit about that and how changes could result in greater housing equity.
Yes, thank you. I really want to build on what Webb was saying about segregation and redlining, how land use has been segregated through the policies. But I want to focus on the local impact of those policies and how they translate on our zoning codes. And we know that a lot of redline areas, as well as those exclusive covenants that excluded people of color from buying homes in certain desirable areas, how those areas translated on zoning. And predominantly, single-family zoning has been preserved and protected for white affluent residents. And a lot of it still exists in our policies. Currently, Denver, about 80% of our land area is zoned for single family. That not only excludes people of color who were not able to build that generational wealth, but also used to exclude non-typical households. So non-traditional families were not allowed to live in a single family zoning. So there's two initiatives that I'm really interested in focusing on is relaxing the zoning or relaxing restrictions in single family zoning. One is group home living that would allow 8 unrelated adults to live in a home, share a house. Interestingly enough, we allow it for residents over 55 years old, but not for younger folks. So a group of roommates, college age or right out of college, cannot share a home legally in Denver. So there's initiative in Denver going on that would allow for revising the definition of household that would allow 8 unrelated adults to live in a house, but also allowing group homes in our neighborhoods. And the second initiative is what is called missing middle. So that is allowing more households and more families to move into single family resident neighborhoods by allowing what's traditionally a single family home to be divided into multiple units, and maybe allowing 4 or 6 families to live what's traditionally being defined as a single family home that allows for greater affordability. And it just allows for more flexibility and allows more people to live near the services and jobs and educational opportunities that are so desirable. Again, I think there's great promise in both these initiatives on a local level.
Well, as we're getting to our last part of the show, let me just ask our panelists about 1-minute answers here. Joanna, I want to ask you, we are now seeing an emergence of people cultivating backyard gardens, but that has been Revision's core from the very beginning. Tell us about what you're doing, but just about 1 minute.
Sure. So we believe that the people best positioned to solve systemic issues are those affected by those crises and those problems. And so we really use an asset-based approach with our community. We are 81% Latino. The majority of our families do have agricultural roots. And so we build upon the assets. The assets are, there's a significant amount of agricultural knowledge. And so the solution for us for systemic food inequalities and inequities is to grow our own food. That's probably not a long-term solution, but for now, it's what we're doing. And right now we have 150 home gardens in the southwest area of Denver, mostly in the Westwood neighborhood. Each garden is about 400 pounds of fresh produce in the community. So that equates to about 60,000 pounds of fresh local produce in a neighborhood that otherwise has no access. And so we're really working on using and leveraging communities' assets to create those long-term systemic changes and solutions.
Well, Rudy, I want to go to you next as we get close to the end of the show. I know this is tough probably to do in a minute, but there have been lots of articles lately about the mental health impact on the pandemic. Tell us about the promising strategies you're using and what kind of policy or maybe systemic changes you'd like to see in behavioral health. And again, I'm sorry that's in about 1 minute, but give us the shorter version if you would.
Thank you. Behavioral health has really exponentially increased the need for those services in this pandemic. I think with the obvious ongoing protests across the globe is a result of a perfect storm of the pandemic of systemic inequities that include law enforcement, economic, what Webb and Goisha was talking about. All of these have come together to create an incredible perfect storm around trauma, around anxiety, depression, anger, tension, and it is playing out in our streets, and it is playing out during a pandemic. And so when we talk about what Servicios does is we have an incredible behavioral health team that we provide a practice that's steeped in anti-oppression framework, which we take into account a very socio-economic trauma of people's past, trauma-informed care around those social determinants of health, around those systemic inequities that include police brutality, include poverty, include jail, prison, gangs, the streets. Poverty, as Gandhi says, is the worst form of violence. And saying that, you scratch inequities and systems, it all relates to economic inequities. And so again, Servicios is being, right now we're kind of overwhelmed because we're just seeing so much need out there. So I will say that the inequity of funding, of resources going to community-based organizations that are providing culturally responsive and linguistically specific services with behavioral health, that includes mental health services and substance use, needs to be increased. It needs to be addressed, and organizations need to be supported and embraced in those that are doing that hard work.
Well, it certainly needs to happen. Again, we're close to the end of the show. Tony, give us a quick 30-second or 1-minute answer. Tell us about some of the initiatives that your center is doing going to address health inequities in the African-American community. Give us just a short answer what's going on that we should know about.
So the Center for African-American Health, we've been around since 1997. 2005, we've added some additional services where we look specifically at the social determinants of health, and also looking at those comorbidities within the African American community by providing programs and education around prevention of cardiovascular disease, diabetes, those comorbidities that are prevalent within the African American health community. But we've also expanded to where we have a status now of a family resource center where we are addressing the root cause problems. So we're connecting people with resources around housing, food, clothing, employment, education, really looking at those underlying issues that kind of feed into those comorbidities. We've also, echoing what Rudy said, is, with these services, there's also, the lack of funding. So, making sure that we have the resources to provide these services. We've partnered with the city and the state so that they can understand the needs of the community. But again, the funding is very important to keep these services and programs going.
I want to thank our wonderful panel for joining us today for On the Same Page. If you'd like to watch this show online, please check it out at pbs12.org. And please check out our next discussion on Friday, July 3rd at 7 p.m. right here on PBS 12. If you'd like to join the conversation with your own question or comment, please feel free to call 303-991-5027 or go to changingthenarrativeco.org. For everyone here at On the Same Page, I'm Dominic Dezzutti. Thank you so much for watching. Good night.